Welcome to this podcast from the Medical Journal of Australia. My name is Sam Hunt, the MJA's News and Online Editor. Today we're discussing what doctors and their patients need to know about bowel preparation for a colonoscopy. Estimates show that up to 63,000 colonoscopies undertaken in Australia may not be useful because of inadequate bowel preparation. That's prompted Bowel Cancer Australia to launch a new website to help Australians prepare for colonoscopies. To learn more, I'm joined by Associate Professor John Ding, a Melbourne-based gastroenterologist and a Bowel Cancer Australia spokesperson. He is also the lead for the National Bowel Cancer Program at St Vincent's Hospital in Melbourne. Associate Professor Ding, thank you so much for joining me.
Thank you so much, and it's a real honour and a privilege to speak to your audience today. So thank you for having me on.
And John, I'll start by asking you, how widespread is bowel cancer in Australia?
So bowel cancer is quite prevalent in Australia. It's currently the third most common type of newly diagnosed cancer in the country. In 2023, it's estimated that over 15,000 Australians will be diagnosed with bowel cancer. And sadly, about 5,000 die from the disease each year. Significantly, I think the numbers and percentages show that about 11% of all diagnoses are actually among people under the age of 50 now. And that age group accounts for about 6% of all deaths. So it really does also underscore the importance of early detection and screening, because as we know, that does save lives. And as your GP audience and others will also know as well, certainly being aware of this as a possible diagnosis in younger individuals is clearly important.
So it is quite prevalent. And how many colonoscopies are done each year? And in how many of those do you and your colleagues see inadequate preparation?
So in Australia, currently probably more than 900,000 colonoscopies are performed annually. A lot of this is kept obviously on a registry, and there are also quality metrics that need to be collected as well, both as an audit level from ourselves individually, but also in order to attain reaccreditation, we must require a certain level of quality in that process. Part of that involves removal of polyps, and we need to meet a certain polyp detection rate in order to be reaccredited. But increasingly, there is an interest on performing colonoscopies with adequate and excellent bowel preparation. And that is really up to us as the gastroenterologist or colorectal surgical specialists to be able to explain things clearly and prepare the bowels appropriately for the patient. So these data that has been released clearly show that the utilization rate of colonoscopies as a diagnostic and screening tool is increasing. But the quality of the prep is clearly a significant part of this as well. And it is an issue with inadequate bowel preparation. And the research would show that indicates about a quarter of colonoscopies may be associated with suboptimal bowel preparation. And what that directly links to is an increasing number of missed polyps and also, unfortunately, a number of interval bowel cancers that can be detected either before a colonoscopy is required as a surveillance. So inadequate bowel preparation really does have significant consequences for the individual patient, for us as the performers of colonoscopies, but also healthcare costs, because a lot of patients do then need to be rebooked for a colonoscopy, which can often take up another spot, which may be taken by someone else. And then a missed colonoscopy could be an opportunity to diagnose cancer for another individual at an earlier time point as well.
Now, the process of bowel preparation for a colonoscopy can be quite involved. What are some of the myths that you'd like to bust about preparing for a colonoscopy?
When we talk about bowel preparation, I've been through it myself, so I've walked the walk, and I can certainly speak about this as well. I often hear from patients who come in really significantly concerned about a few things, and these are the myths, I suppose, that we're referring to about bowel preparation. You know, they've watched maybe a comedy sketch, and that comedian that might be speaking about how terrible it is and the experience of it all. But there are a few myths. And one is really that diet doesn't affect the bowel prep quality. It really is important, I think, in the days leading up to the procedure, in order for better cleanliness, that one adheres to the diet portion of it as well. So we commented about 3 to 5 days in some people of a low fiber diet a few days before the prep, which includes also low residue, meaning there's no seeds and nuts in it. Another clear myth as well is that all bowel preps are terrible and unpleasant. Interestingly, there have been a lot of research from the bowel prep companies themselves. They're clearly invested in making the prep more, let's say, palatable and a more comfortable experience. But clearly, some can be more tolerable for certain individual people than others. So it might be a case of not necessarily try before you buy, but being familiar with certain preps, maybe a lower volume, certain preps have a greater volume, and that is often selected by the specialist that's performing the colonoscopy. Another myth might be that the entire prep needs to be just taken all at once in a very short time. That's not true. Prep clearly can be taken over a period of time. It's as long as the individual, the patient, has taken the prep in its completeness and has a clear return or outcome from that is also very important as well. It is also the case that bowel prep that isn't perfect does not necessarily mean that the colonoscopy needs to be cancelled. So oftentimes we see that maybe a patient might be concerned, they just have a little bit of sort of yellowish tinge, let's say, to the effluent waste that's coming out. Now, it doesn't mean that we have to cancel colonoscopy on the basis of that. As long as most of the effluent is liquid, we can then suck up a lot of that using a flushing and suction techniques, which are part of the hardware of the colonoscopy itself. And this has improved over time with an increased channel ability to be able to suck up larger bits of waste as well.
That's some good myth busting there. All right, let's talk through the process of bowel preparation. You've got some quite detailed information to give us.
Yes, there are several detailed steps, and slightly there can be adjustments on the basis of each individual endoscopist that's performing the actual procedure. So it's not a one-size-fits-all. That what I'm saying as part of this bowel prep process is actually just general advice about what happens in the days leading up to the colonoscopy itself. So the first being the dietary changes. We start by beginning with a low residue diet a few days prior to the procedure in order to ease the cleansing process. And as I said already, this is really crucial because what means is that the actual bowel prep itself may be a gentler experience for the patient. I wouldn't say enjoyable, but just gentler. In terms of the laxative prep product that is prescribed, some patients who have constipation as an issue, I sometimes talk to the patient about perhaps starting on some osmotic laxatives. And what that means is obviously softening the stool. So patients with constipation as a problem, I often start by saying, look, you can try by using some Movicol, 1 sachet a day at least, in the 5 to 10 days in the lead up to the actual bowel preparation itself, the night or the evening before. That can lead to a better experience and a better outcome as well for patients with very slow transit bowels or constipation as an issue. Now, the clear liquid diet is usually started after a light breakfast the day before. And that clear liquid diet can start for some people in certain instructions after a light lunch as well. But generally speaking, I think after a light breakfast is mostly what endoscopists would prescribe. And so switching to liquid diet, meaning that you can see through this liquid itself, could obviously be water, clear broths, certain juices, as long as there's no pulp in it. The fasting process, and we normally say this now, is that according to the College of Anesthesia, they have adjusted their requirements for fasting of liquids in the leading up to these procedures. Endoscopists And they're quite safe now because the studies have demonstrated and shown that 2 hours of no clear fluids or liquids is safe in order to empty the stomach and decrease any risk of aspiration. To be safe, some instructions would say 4 hours before turning up to hospital, no consumption of liquids, including water. And then certain medication adjustments, which has to be individualized. Of course, we know about diabetic medications. We also have an increasing awareness, clearly, of weight loss medications such as Ozempic, which are clearly very topical at the moment. And those do need to be stopped often weeks before the colonoscopy or gastroscopy nowadays as well, because we know that it leads to a decrease in the emptying of the stomach, and unfortunately in some cases has led to outcomes which include aspiration if this is not adhered to. Iron tablets also need to be stopped for about a week before, because that can stain the actual stool itself and also perhaps stain the actual mucosa lining of the colon itself, and so it can blur the pictures that we see. And in terms of the actual bowel preparation, as I said, there are preferences for each individual endoscopist as to what they like in regards to the particular product that they might ask the patient to purchase from the chemist. It is something that's best prepared, with large containers around and drunk slowly over periods of time. What I would say is usually, obviously, there is certain timings, again, on various instructions that we need to pay attention to. But the best evidence now is that for a better outcome, which leads to increased detection and better cleanliness of the colon, one needs to have what we call split dose bowel preparation. And that means that actually taking a dose on the day of the actual colonoscopy itself, it means that the runway time, which is the time that it's in the lead up to the actual colonoscopy, is as short as possible, because that often leads to better outcomes with detection of polyps. And this is seen in the right colon in particular. The right side of the bowel can often be stained, perhaps by small bowel waste product that comes through. And it's been demonstrated that by taking bowel prep quite soon to the actual colonoscopy, maybe in the 4 hours or 6 hours before a colonoscopy, that this is a clearer outcome for the right colon and leads to increased detection of particularly these sessile serrated polyps, which often get missed. And after the procedure, you can usually return to a normal diet unless instructed otherwise, obviously, by the doctor, or if there are worries about complications as well. But as I said, each individual healthcare provider has personalized recommendations, and just to follow those recommendations would be important.
And specifically thinking of GPs, what are some key things GPs need to be aware of when referring a patient for a colonoscopy?
Yes. And I'll start by saying that GP specialist colleagues are fantastic and really at the forefront of this, let's say, battle against bowel cancer. And so, I absolutely commend all the GP specialists out there who do an excellent job at trying to sieve out what might be bowel cancer from perhaps what are functional symptoms that could be resolved by other measures. And so it's a very complex question, but clearly nuance in the fact that the patient's symptoms are key to everything, and being clear, obviously, about symptoms and screening guidelines for the prompting of that particular referral. As your audience would already know, I won't go into too much detail there, but blood in the stool over a number of days is clearly not normal. Also, abdominal pain, weight loss, changes in bowel habits, and bloating as well as a symptom. These all can be, of course, functional symptoms, but at the same time, I think warrant either a referral to an endoscopist in some circumstances if it's unclear, performing fecal occult blood tests, which is obviously available to us here in Australia as well as part of maybe the screening process, and then prompting perhaps a colonoscopy on the basis of some of these results. In terms of the medical history as well, being able to divulge or being clear about patient history that can affect certain procedures, and such as colonoscopies, including abdominal surgery, history of inflammatory bowel disease, which hopefully also the specialist will be aware of as well. Any medications that might need to be ceased in the days leading up to a colonoscopy, such as anticoagulants, antiplatelet therapy. We are comfortable as endoscopists now to perform colonoscopies on aspirin. So I would say that there is no need to stop aspirin as a general rule for all colonoscopies, because this has not been shown to lead to an increased rate of post-polypectomy bleeding. But other anticoagulants and antiplatelets do need to be considered and stopped in certain circumstances. Clearly, if the risks outweigh the benefits, and then we wouldn't stop it, and we may perform a colonoscopy on these antiplatelet and anticoagulant agents as part of screening to detect whether or not there's bowel cancer or a large polyp, which then will increase the impetus to stop these to remove polyp later on. And previous results as well of any relevant blood tests, blood work. Importantly, I think renal function. So if some patients have got chronic kidney injury, we might select a increased volume bowel preparation, such as Prep Kit C, Pica Prep. These often come with a litre of fluid and have less, not only fluid shifts, but also electrolyte shifts as well. The bowel prep, as I said, is important itself, and having resources perhaps that may be available for the patient to understand that it isn't as terrible as some would believe is also important, and encouraging, I think, the patient themselves to show up and to have a colonoscopy as well is important. And GPs, specialists, do play an essential role, I think, in part of this discussion as well, to understand the procedures.
And of course, Bowel Cancer Australia has launched a new website to help people prepare.
Yes, it's a very catchy link, isn't it? We had thought long and hard about it, but landed on bowelprep.au. And Bowel Cancer Australia really ought to be commended on trying to make this as easy a journey as possible, and in doing so also debunk some of those myths about how terrible bowel prep can be for individual people. I worked on it with Bowel Cancer Australia. So as someone that has real skin in the game with performing colonoscopies, I found personally that unfortunately bowel preparation was just not well understood, and unfortunately also not well performed. And that's not because of the patient. Oftentimes it's because the instructions that are received are not clear, are not legible, in some circumstances, and are often too old and outdated as well. And this isn't just to sort of make a point here. So we're just really trying to bring a resource to patients that will enhance the experience and improve the experience, and hopefully lead to a better outcome, which is that patients can enter the colonoscopy room ready to go with as clean a bowel as possible, so that the endoscopist can perform the procedure safely, as well as detect any polyps as well in a timely fashion. So what it actually is to have instructions that are available on phone or on anyone's desktop as well. And it links directly to certain steps as well, based on the fact that when you enter the app, you'll be asked about whether or not when the actual colonoscopy is to be performed and what type of bowel prep is to be used. Based on the algorithm at the back end, what it does is to prepare a set of instructions that are quite generic, again, taken from over 100 bowel prep resources that we've seen. And we've been able to glean all of this information thanks to a few expert endoscopists, as well as the conjoint committee for training in endoscopy and colonoscopy. And in doing so, we've arrived at what is a very general but yet quite specific set of instructions that helps patients to prepare in the best effective way. And this includes the diet preparation in the days leading up to it. And these reminders and notifications will be sent directly to the patient's phone, on their calendar, in fact. And will then notify the patient when to start the actual processes and steps. Once a step's been completed, this can be ticked off by the patient. It also leads to us as the endoscopist being confident that a patient's actually followed these steps, because there is this metric that we can collect at the back end. So we've really condensed years of learning and multiple bowel prep instructions into what is a very simple to use platform that patients can access on their phones, notifications, as well as on their laptops. There was a trial, in fact, that was conducted, Sam, about 1 to 2 messages that was delivered in the days leading up to a colonoscopy led to improved bowel prep quality by about 2 points. And that increased the polyp detection rate and decreased chance of missed polyps and, worse still, cancers.
Associate Professor John Ding, thank you so much for your time today.
Thank you very much again for your time, and thank you to your audience for their time and listening to the podcast.
My special guest has been Associate Professor John Ding, a Melbourne-based gastroenterologist, a Bowel Cancer Australia spokesperson, and the lead for the National Bowel Cancer Program at St Vincent's Hospital in Melbourne. You can find more information about preparing for a colonoscopy at bowelprep.au. And you can find more podcasts from the Medical Journal of Australia on our website at mja.com.au or wherever you get your podcasts. Thank you so much for listening.